Hello, everybody. My name is Chauhan. I'm one of the medical oncologists at University of Miami. I lead our neuroendocrine cancer program and co-lead our theranostics drug development program at Sylvester Comprehensive Cancer Center at University of Miami. Thank you, LACNets, for giving me this opportunity to talk about NET-RETREAT study. You've all heard about how transformative PRRT has been for our well-differentiated neuroendocrine tumor patients. It's a precision or tailored way of administering radiation to our NETs patients, and has been a runaway success. The NET-1 randomized control study, an international study, which evaluated PRRT or Lutathera, Lu-177 dotatate, confirmed its superior effectiveness as compared to control arm, which was higher dose somatostatin analog. And based on NET-1 study, it was FDA approved. And fortunately, now our patients don't have to go outside the US to get PRRT. They can get it within the US. It's on label for progressive metastatic gastroenteropancreatic. That means GI origin, midgut, small bowel, and pancreas neuroendocrine tumors. So Lutathera is now mainstream approved drug. However, if patient receives Lutathera for progressive disease and enjoy stability with Lutathera, let's say 2 years, 3 years, 4 years, and then eventually the cancer starts progressing again, the intuitive question that will come to anybody's mind is, oh, it worked so well in the first round, let's try it again. And sometimes we do try it again. However, in the retreatment setting, PRRT is not FDA approved. We just haven't tested it in a prospective, randomized, multi-center clinical trial. So we don't really know in true sense the safety and effectiveness of repeating the PRRT. However, we do have some data from Europe because they've been using PRRT for a really long period of time. And all those single center retrospective studies from Europe do suggest that, yes, we can safely retreat patients with PRRT at time of progression. And yes, it is also effective, not only safe, but effective. However, in the US, if we want to convince the people who make guidelines or the insurance folks, we need to generate prospective data to really validate, is it safe and is it effective? And I think scientifically also it's really important to study it so that we are not harming our patients by retreatment and providing them the best medication for progressive disease. This is where this study was born because of the unmet need for this patient population who's progressed on PRRT. And this is an NCI-sponsored study. It's a collaborative effort between SWOG, which I'm a member of, and CCTG, the Canadian Cancer Treatment Group, Dr. Simran Singh. So we are co-leading this international multi-center study. We expect that a lot of centers across the US will open the study so the patients can easily access it within their state and city. We are also collaborating with some of the world-renowned investigators, nuclear medicine doctors, and radiation oncologists for this study. And we have a very strong study team, as you can mention here. This study is approved, IRB approved, has blessing from FDA, and we are expecting a launch any moment now. So let's talk a little bit about study design. So all the patients who have midgut neuroendocrine tumor, this is the same patient population which was originally tested in NET-1. So all the patients who have progressive midgut metastatic neuroendocrine tumor had previous treatment with Lutathera and had at least enjoyed stable disease for a year after Lutathera can be considered for this randomized controlled trial. The study has 2 arms. So about 2/3 of the patient will have chance to get randomized to repeat treatment with Lutathera. It is not going to be 4 doses again. It'll be this time 2 doses because the radiation is exposure is counted as a cumulative over the lifetime. And we believe, based on the existing data, that it is safe to do 2 more doses, but we just don't have the comfort or the safety data for additional doses beyond that. The control arm, so 1/3 of the patient would be randomized to control arm. And I personally don't like to give sugar pills or placebos to my patients. So the study is designed to give a very effective and standard of care drug called Everolimus. So both the armed patient would get an actual proven drug with safety track record. And we would be looking into, our primary objective is to see which drug does better in terms of disease stabilization, progression-free survival. And of course, we'll also look at the safety and side effect profile for both these arms. At the time of progression, if the patient randomized to Everolimus arm, the control arm, and they did not benefit from it, or eventually tumors start growing, they can then get the Lutathera additionally. So it's a win-win either way for both the arms, because eventually they can get the retreatment with the Lutathera. So why should the patient consider this study to participate in this study? A couple of reasons. One, scientific inquiry. So this study would really help us build the foundation about and help us fill the knowledge gap regarding, is it safe to repeat PRRT, and is it effective to do PRRT in a retreatment setting? So it's really important, because we just don't want to treat without that long-term and short-term safety and effective efficacy data. So this will not only help patients now, but the future generation of patients. Secondly, because there is no randomized prospective data looking at a repeat PRRT, the current guidelines don't really have strong recommendations in favor of it. So that might help change that, and which might make it easier for patients to get it approved through their insurance down the road if the study turns out to be positive. And thirdly, and most importantly, during the study, we are collaborating with NCI, where the Lutathera will be provided by the study sponsors. So it really makes it easy for our patients to receive these additional off-label doses of Lutathera, which otherwise their insurance might not cover. So there's always that issue. So I think otherwise the study is pretty straightforward. The Lutathera will be administered the way it's given as a standard of care, 1 dose every 2 months for a total of 2 doses in retreatment setting. And Everolimus is administered as a daily pill with the option of changing the dose based on the tolerability. We look forward to launching this study shortly and making the study available to many cancer centers across the US and Canada. And I urge that you help us enrolling in this important study, which will help patients not just now, but the future generation of neuroendocrine cancer patients. With that, I'd like to thank you for your attention and thank LACNETS for this opportunity to help us throw some light on this important study. Thank you.